Good evening, everyone. And hello to the people watching online. We're going to go ahead and get started. I'll stand for the beginning part. My name is Sarah Arts. I'm the CEO for Special Olympics Alaska. Welcome to the Family Health Forum. Super excited to see all of you here tonight, and also very excited for the opportunity to discuss Down syndrome regression disorder and also talk a little bit about the healthcare journey and how tonight's format will work. We have Dana and Darcy Owens that are going to share their personal healthcare journey. And then we have Dr. Santoro here, which we're very excited about, and he'll share a little bit about Down syndrome regression disorder. And then there'll be a lot of time at the end just for open questions and discussion. So you'll all have the opportunity to ask any questions that you have and have conversation with Dr. Santoro. And where's your mom, Darcy? Oh, there she is. Why don't you introduce yourself, and then your mom can introduce herself next. Nervous. I'll turn it over to Dana.
First of all, thank you so much for being here and showing an interest in this topic that is so very dear to our family and so dear to my heart. I'm Dana Owens, and this is my daughter, Darcy. And we've been involved in Special Olympics for over 21 years, and so this is our second home, and this is a very special family to us. And so being able to bring up a presenter the caliber of Dr. Santoro is just something that I never would have thought would have happened when all of this journey started. So thank you for that.
Hi everybody, my name is Darcy. And this is my specialist, Santoro.
Thank you, Darcy. So I'm John Santoro, coming from Children's Hospital Los Angeles and Keck School of Medicine over at USC. I've got a very brief presentation that I wanted to go through just because I think that seeing images can often be very helpful for trying to put together what Down syndrome regression disorder is. Talk very briefly about that, but very much looking forward to answering your guys' questions as well once we get through that. So with that, I'm actually going to shift over here so I can click through the presentation as well. So we'll take it from the top. So why does somebody who cares for people with Down syndrome care about immunology, right? And so the key here is that people who have Down syndrome have an extra chromosome 21. And on that chromosome, there's a lot of stuff. And one of those things is interferon receptors. And these are kind of the Paul Reveres of your immune system. So that means that people with Down syndrome have 50% more of a response to infections, to stress, really anything that the body would kind of trigger. We know that this is linked to a higher prevalence of autoimmune disease that we see in people with Down syndrome. That's Hashimoto's disease in the brain. But when you have a genetic condition, all of the cells of the body are affected. And so that's why it's really important to kind of think about how this could be affecting the brain as well. So when we talk about regression, regression can be many things. And when we think about developmental milestones, typically it's something that you attain and then you keep it. But in regression syndromes, you start to lose those milestones, the ability to take care of yourself, the ability to communicate, the ability to socialize with other people. And there's many times in life where this could happen. In individuals with Down syndrome, they're at 100 times greater risk for things like infantile spasms or epilepsy very early in life. That can be a cause of regression. We see that there's a 20x risk of autism spectrum disorders. And I'm sure many of you know people who have both Down syndrome and autism. Obviously, we'll talk about Down syndrome regression disorder today, but even Alzheimer's disease could really be thought of as a regression syndrome because you're not able to do all of those activities like you were before. So I want to talk about what some of the features of Down syndrome regression disorder are. And there's several of them. So the key here is that with Down syndrome regression disorder, the onset of these symptoms on the right side of on our right, stage left, our right of the screen are sudden and they're dramatic. These are days to weeks, not months to years that it takes for these symptoms to develop. They can be preceded by a stressor or an infection in about half of the cases. And for the purposes of today's talk, we're talking about people who have the onset of these symptoms between 10 and 30. Now, we use that for operational understanding, but there's definitely patients younger than that, and there's definitely patients older than that who may have some of these symptoms as well. The reason why we kind of try to keep it narrow is that if you're under 10, the chance that you actually have autism is greater, and if you're over 30, the chance that you have Alzheimer's disease is a little bit greater. But as you can see, and I'll show some videos of this as well, insomnia or difficulty sleeping, catatonia, muscle stiffness, the inability to initiate movements, obsessive compulsive tendencies, and this isn't somebody who likes to keep a very clean house, right? We've all joked that a member of the family has OCD. This is compulsory behaviors where you have to touch the doorknob 100 times before you can leave the room. We see psychosis, agitation, hallucinations and delusions, and a loss of language or whispered speech as well. And this condition's been known about for about 80 years. The first report of this was from 1946, and this condition was thought to be psychiatric for a very long time. Only until a couple of years ago did we actually figure out that there was an immune basis for this condition, and it was actually treatable and in some cases reversible. So I'll show you some examples of catatonia. So that young man that I showed you in the prior image who was very stiff, was kind of stuck, he had a very stooped posture. This is one of our patients from California, who you can see also has that stooped posture, and he's lost 40 pounds because he can't feed himself anymore, and he's having difficulty swallowing. You can see that when my assistant there moves his arms, he just gets stuck. He's like a mannequin. Now, if you put him into a different position, he'll remain in that position until you take him out of it. We also see that there's a lot of repetitive behaviors or abnormal movements. So this could be something that we see in people who have autism spectrum disorder as well, but this is new. And so this is a young woman who participated in one of our clinical trials, who from the moment she wakes up until the moment she goes to sleep at night, does this repetitive movement over and over and over again. And if you try to stop her or feed her, she gets agitated, she gets aggressive, and goes right back to it. She actually had developed, by the time we saw her, she had developed calluses over her knuckles because she does that movement so many times every day. We also see that many of our patients start responding to things that aren't there. This young woman is sitting in our exam room, nobody's talking to her, nobody's interacting with her, but she'll kind of giggle and grimace, and sometimes she'll cry, or sometimes she'll laugh, and there's nothing else going on in the room. Oftentimes this happens in the middle of the night, 2, 3 o'clock in the morning. Somebody will just wake up and start laughing or crying, for no reason. At the same time that these neurologic and psychiatric symptoms start, we also see that there's other things going on in the body. So in about 70% of our patients, they'll develop really bad skin disease, like you can see in the bottom corner over here. Now, individuals with Down syndrome have hidradenitis, they get boils, they get all sorts of skin conditions. But this is new and really bad at the time it starts. We also see that about a third of patients will have really bad constipation, or something, a medical term for that is ileus, where the gut completely stops moving. We also see a lot of hair loss and alopecia, which is where you get clumps of hair that fall out all at once, and then amenorrhea or dysregulated menstruation. So our female patients stop having periods at the time that this starts. All of this indicates to us that there's a systemic problem in the body that is also affecting the brain. Here's just some other examples of the skin disease. You can see this young man has a red irritated plaque along his forehead. When we put it under UV light, it fluoresces, just showing you how extensive it is. This young man has those plaques along his beard. And then this young woman has developed really severe photosensitivity, which in a place like Los Angeles is very problematic. We also see that some of our patients will develop vitiligo, or a hypopigmentation of the skin. What's really fascinating is most people who develop vitiligo, it takes many years, and I think the easiest example is Michael Jackson, right? So it took him a really long time to start losing the pigment in his skin. This is very rapid. This is 6 months. He's gone from totally normal skin to almost a third of his body being covered without pigmentation. Here's an example of alopecia, where this young woman had lost clumps of hair all at once at the time that these symptoms were starting up. So I'll show you some images and kind of explain what we do when we suspect or we're concerned that somebody has Down syndrome regression disorder. So there's a lot of testing. And so I think that the biggest challenge for us is when you suspect Down syndrome regression disorder, it's a diagnosis of exclusion, meaning that as doctors, we have to rule all of the other potential explanations out before we make that diagnosis. So there's blood work, that helps us rule out metabolic problems, infections, some inflammatory problems. MRI helps us look at the structure of the brain, make sure that this isn't a stroke, make sure that there's not a structural reason for a problem. We use EEG or electroencephalogram, the little electrodes that go on the top of the head to make sure that this isn't a seizure disorder, which people with Down syndrome are 10 times more likely to have. And then finally, we do something called a lumbar puncture. For those of you in the room, how many had an epidural when they had their babies? Couple, okay. So, very brave crowd here. So with a lumbar puncture, what we do is your brain is protected from your body by this thing called the blood-brain barrier. And it's good, we want it to be protected. If you get a virus, the reason you don't get meningitis every single time you get sick is that barrier keeps everything out. But it also prevents me, when I test from the blood, to know what's going on in the brain. So that procedure goes past that barrier and samples some of the fluid. It's probably our most important test to detect brain inflammation. And the timing of that testing really matters. So sometimes it takes a long time to get to the right doctor to initiate the testing, but you can see in these kind of 3 bars that go down over time, after about a year from the start of your symptoms, the chance that we capture the abnormalities that we're looking for starts to go down. So if you have a loved one or if you hear of somebody going through what could be regression, it's very important to get evaluated early and then get the testing for it so we can confirm the diagnosis. When we look in the blood, we don't find anything sensitive or specific. But on the MRI, and I don't think you have to be a neuroradiologist to see this, so the arrows should be helpful, we see a lot of weird things. We see these white spots that indicate that there's injury to the white matter or the highway connections between the brain. We also see these dark spots. These dark spots exist in a part of the brain called the basal ganglia. But what's really most important is not the name of that area, but that part of the brain controls movement initiation. So when we think about those prior images of individuals who just seem stuck, they can't move themselves, this makes a lot of sense because it seems to be that there's injury to that very important part of the brain. And what we find is that when you have that injury, those black spots in the center, that you're 8 times more likely to respond to immune therapy. And this is all relatively new. We only started treating patients with immunotherapy about 5 years ago. But we find that this is the best way to actually get patients to have some recovery or complete recovery, especially if you start treatment early. So one of the questions I get a lot, is this Alzheimer's disease? And at first we didn't really know. We do these workups to make sure, but now we've done a lot of testing, and we found that in individuals who have this, and this is just some scientific graphs to show that individuals with Down syndrome and Down syndrome regression disorder don't have any difference in their biomarkers for Alzheimer's disease, indicating that this is not early onset Alzheimer's. So what I'll propose to you is that we kind of have this perfect storm. We have the genetics that predispose you to inflammation. We have something that starts to trigger your body, whether an infection or a stressor or something like that. We have potentiation of known inflammatory cascades that everybody with Down syndrome can have activated. You develop the symptoms of DSRD, but also you get systemic inflammation. And I think our current understanding of DSRD is that something sets off the body and that then triggers the brain issue. So that all of these things are happening in conjunction with each other. This is not an isolated brain disease. There are treatments, but for 80 years we've been treating this as a psychiatric disease. So a lot of our known therapies are antipsychotics, antidepressants, benzodiazepines to help treat catatonia. But really what we found over the last few years is that immunotherapy is highly effective and works pretty quickly to help patients. These are just some graphs to show that when you get treated, patients get better pretty quickly, and when you take off the treatment, about half of the patients actually retain what they're gained. So we don't have to keep patients on immunotherapy for the rest of their life in about half of cases. The other half, as we start to space things out, that's when we can see some of the return of some of the symptoms. We're also now trying to experiment with immune suppression. So at first we didn't want to use anything that was dangerous to patients. Immune suppression is not always a good thing. But now we found that in individuals who already respond to immune boosting medications like IVIG, we can now use immune suppression to get even more of a positive benefit over time. I think this is one of my favorite examples of patients responding to therapy. And I'll show you a video of a patient who clearly has a response, but this is a test called the NEPSI, where the instruction is to draw a line between the car or the motorcycle and the finish line. Usually this should take us 5 to 10 seconds. Off therapy at baseline, this patient is unable to complete the task. She just colors in the boxes, and that's it. On therapy, she completes this task in about 10 seconds. Off therapy again at week 40, she just starts coloring in the boxes again. Right, so a nice visual representation of what these treatments actually do. The treatments that we're using right now, by far the most common is something called IVIG, or intravenous immunoglobulin. What this is it's pooled good antibodies from thousands of other people, so it actually doesn't suppress the immune system, it gives you a boost and gets your own immune system back into check. The other 4 medications that we have listed there, those are immune suppressing therapies, something that we're starting to use more frequently, but we're not there yet for the hard data to support the use of everybody. I want to show you some patients who improved. So right, we showed those slides of people who had lost hair at the same time. So this is one of our young men who had a big patch of bald spot, and then started on therapy, a little bit of peach fuzz, and then the hair starts growing back, right? So we're not treating this patient for hair loss, we're treating them for their neuropsychiatric disease, but they're having other benefits as well. You can see from the back, starts to grow that in. From the front, starts to grow that back too. And we have a very happy customer who now has his eyebrows and eyelashes back as well. We also see improvements in the catatonia. So this is one of our young men. I don't know if this is going to play. Well, I can tell you what happens because it's a very still movement. This young man has catatonia. You can see his arm is stuck right in front of his face. For the next few minutes of this video, all he does is sit there. That's all he can do. Eventually he ends up pointing. After about 8 weeks of treatment, this won't play either. Oh, bummer. This young man is hitting the gym, boxing, doing all sorts of crazy stuff, back to his life as it was before. And he is from Canada, has done some nice photo shoots, and now has met with a bunch of Canadian prime ministers, and is really the spokesperson for DSRD in Canada as well. That's about as fast as I can talk about a very complex disease, but I'm happy to answer questions. But I think that Dana and Darcy are some great resources for kind of the journey of how people come to medical care. And even though we're separated by many thousands of miles, as I realized traveling up from Los Angeles to Alaska, we're all part of one community. And I think that one of the most important things for me is coming up here, showing you that there is a face to the people who are doing the research in this area, trying to make the lives of people with Down syndrome better as well. So happy to take any questions, and I'll hand it back to Sarah.
We're going to have Dana share their healthcare journey, and then we'll open it up for questions.
Cool.
Okay. So for those of you online, we had a little technical difficulties, so you're currently on an iPad being wheeled around. So I'm going to turn it over to Dana to share a little bit about their personal healthcare journey, and most of you know Dana and Darcy, so I'll let you take it away.
Gotcha. Well, let's start out at the beginning. Darcy was diagnosed in utero, so we knew before she was born that she was going to have Down syndrome. So we did a lot of testing, we knew she was going to have a hole in her heart. And so when she was 4 years old, we had open heart surgery. But as far as other developmental milestones, Darcy did really well. A little bit delayed, that we all know of, like the developmental milestones, but Darcy had a very uneventful health journey. She had ear infections. I think that's pretty common with Down syndrome. We had lots of ear infections and tubes. But through elementary school, Darcy was fully included in school all the way up through high school. She was in the marching band in high school. She was the, the basketball manager at Eagle River High School, voted prom queen of high school, and so she was very social. So that, those of you that know Darcy that's not a surprise at all to any of you. That's where Darcy operated, and we just had a great time at life after high school. Darcy went to the ACE and ACT program to learn skills. We did all that stuff, and she ended up working at Special Olympics. She was, what was your job?
Initiatives assistant.
The initiatives assistant at and so she did a lot of public speaking, a lot of Special Olympics gave her the spotlight to shine a lot. So we're very thankful for that. So when Dr. Santoro talks about rapid onset of symptoms, I can tell you the week that Darcy regressed. Not that we didn't have some signs before, there was some, like maybe a couple weeks prior, some confusion, like Darcy loved to unload the dishwasher. And so to get a spatula, she'd look at that and go over to the pantry, and we're like, what the heck? And so anyways, but we came around with that. And so that was the time that we knew something was happening. And we made a appointment with our primary care provider, which, wonderful, she knew Darcy from the time Darcy transitioned from pediatrics to adult life. She had a familiarity with Darcy. And so when we went in for our visit, she's like, yeah, something's a little bit. We thought maybe it was anxiety, just like not knowing what it was. And so they placed her on some medication, and Dr. Santoro reassures me this wasn't the medication that did this, but that next week, Darcy regressed, April 11th, 2022. It was just her time to regress. And so what regression looked like for Darcy could have been the poster child for everything that Dr. Santoro mentioned. Confusion. She lost her ability to speak. She was mute, and for everybody that knows Darcy, that was big. Darcy loved music. Oh my goodness. She stopped listening to music. She wouldn't listen to music. Hallucinations. I have a video, I had to stop the car because she was going to jump out of the car on the highway of just hallucinating. So all of those things in Dr. Santoro's research, is there 8 criteria that you look at? There's 8 criteria of what possibly could be regression disorder. Darcy hit every single one of them, all of the symptoms. And so what did we do with that? We had a wonderful primary care provider who, again, knew Darcy. She's like, I don't know what is happening yet. So we're gonna keep finding, and we're gonna keep searching, because we know this is not right. And so I think as parents, I think it's very important, how do we advocate for our children? We know what is baseline for our children. How do we take records? How do we keep records and explain that to some physicians that might not know our children as well as we do? But Darcy's physician knew. And so some of the markers, Darcy had inflammatory markers. What we identified was she had gut inflammation. It was diagnosed by, we had an upper GI. And so yes, Darcy stopped eating. Well, did she stop eating because what we know now is catatonia? Or did she stop eating because her gut was so inflamed? Darcy lost 30% of her body weight. She went down to 89 pounds. We weighed 89 pounds when we went down to California the first time. And really, had we not found what was going on, how do you correct that? So those were the first things. We found the inflammation. We found, and Dr. Santoro talks about the other little signs. Oh, that big word of the boils. That one. Darcy had all of these little things that in and of themselves are like, okay, we'll put a cream on that, or we'll take, what do you take for your indigestion? For the inflammation of your gut, we'll take a little pill for that. But you put it all together, and it really showed a picture of what was going on systemically with Darcy, but in and of itself, with just the individual specialist looking, they didn't put the pictures together. And so I wasn't satisfied that we weren't getting answers. And so to look at the research, I was able to just Google the symptoms. What is happening? And every article, every research article that I found had Dr. John's name at the top. And I said, well, that's the guy I need to talk to. How do I get a hold of him? So I called the insurance and they said, well, he's in network, just go make an appointment. So I didn't think it could be that easy. But the minute we had an appointment with Dr. Santoro's office, our PCP reached out to him, and Dr. Santoro so graciously walked her through the diagnostics that he talked about. And so we were able to get those diagnostic testing done before we went to go see him. And so when we went down, we were able to get a diagnosis and initiate treatment. Darcy has been on lorazepam, which is the Ativan for catatonia, since day one. Seeing Dr. Santoro, and an antipsychotic. We do the immunoglobulin therapy every 3 weeks. We get IVIG. And so while we see great gains in Darcy. If anybody knows Dining with Darcy show that Darcy did in Special Olympics, we haven't been able to do that just because Darcy hasn't had the skill, the speaking skill. But we did that today with Dr. Santoro with her first guest back. So I think it's something that we're going to keep doing, right? So while we are not back to baseline, we are right there. And with the other treatments that Dr. Santoro is researching and finding those, I think our next step is that JAK inhibitor, what we do to fix that immune system. So that's our health journey, and that's not that, I think one of the things as a parent, searching out answers for your child and nobody knew the answer, you get very frustrated. And it's like, and that was when I saw Dr. Santoro, I was so angry. It's like, why do we feel dismissed? Why do we? And he very graciously said, they just don't know yet. This is new research. Darcy, you've been doing it 5 years, is that it? Darcy has been regressed 3.5 years, so truly that knowledge hasn't been out there. So I've been able to give a little grace. Not everybody knows everything. And so, but that's our job. We advocate, we know what's right for our children. Or we know what's not right with our children when something happens, and how do you advocate in a way that people want to help you and not dismiss you. So we learned that. So that's our journey. We're still on this journey. I think if something that I could have known better at the beginning, it's like, oh, we'll get treatment and we'll be better. This is a marathon, it's not a sprint, and I have to be patient at times because I want, we want it better now. I want that spark, all that, but that Dining with Darcy episode that we did today, Dr. Santoro, you saw that. That was beautiful. So I appreciate that. What else can I tell about my
Questions? Oh, were you? Okay. Can you talk a little bit about some of the roadblocks that you found within the Alaska healthcare system when it came to getting answers about her gut, some of the misdiagnosis that happened along the way, and then just talk really about the piece of you're the one that knows your child, your client, your person, your loved one, and maybe how you didn't give up. So maybe elaborate on that.
Well, I think some of the healthcare, the barriers were just because the physicians don't know. That's part of it. They didn't know what Down syndrome regression disorder was. But I think something, and I'm sure I'm not unique in this, but I'd never experienced, I've heard a long time that individuals with intellectual disabilities, there's medical bias, or there's just, is that the correct word? Whatever, of words. And so I don't know how to educate, but this is what so some of the comments that I got, well, she looks pretty good for Down syndrome. Well, wait, how do you respond to that when I know my daughter had changed, but I don't know, yeah, that's a hard one to explain. I'm like, how do say that, or just being able to, I'm just trying to think back, just being even reluctant to do, we knew she had inflammatory markers just from the blood work, and it was GI related, and the not eating, all of this, I guess I would be confused, why wouldn't you want to look at something that's going on of just the medical, well, we're not going to find anything, so we won't put her through that. But why? And so what I've learned now is a question that you could ask, what would you do if this individual didn't have Down syndrome? Would you go through some medical testing? Would you look further into it? And so now I know that. I would say that. I didn't know that at the time, and maybe I should have. So I think the biggest barrier is just the not knowledge, not knowing what Down syndrome regression is, but then how to advocate when you don't feel you're getting attention or treatment based on a medical diagnosis of Down syndrome. I think when we were having denials for the IVIG and not getting the, insurance was not approving the medication just because, well, there's a lot of reasons why they won't approve it. And I was having a conversation with the appeal people at the insurance or whatever, and they wouldn't tell me why they were denying it. It's like her diagnosis, that's the gold standard treatment is IVIG. And I said, if this denial has anything to do with the Down syndrome diagnosis, then I feel like we might have some kind of discrimination because that's not what we're asking for. Well, the next week it was approved. So if that comment had any bearing, I don't know, maybe it was in the approval process anyways. But I think we just need to be able to advocate, and it's like, just because we have an extra chromosome doesn't mean that we're not worthy of the treatment of anybody else that doesn't have the extra. Is that helpful?
So
No. And so the barrier of not having the information and the knowledge of Down syndrome regression disorder, that's why if you could just tell one person, if you're just aware, and I think this has kind of been my mission since this time, it's like, well, the world has to know, because if I would have known that this was a thing, Darcy could have been diagnosed. It took us 7 months for a diagnosis, and when time is of the essence, how do you get that diagnosis sooner? So that's something everybody needs to know about Down syndrome regression disorder as not a possibility, it's a very small percentage, but if you see the symptoms, know what they are and try to get diagnostics.
So I'm gonna jump in from the side. I know everybody's turning their heads going, where's this person coming from? But I have a question for Dr. Santoro. So I'm the inclusive health manager here at Special Olympics Alaska, and so I talk to some families and I get told stories all the time of advocating for their client or their child's health. And sometimes they're like, oh, that's just normal. That's what they do at the appointments and stuff. And I'm like, that is not normal. That is against HIPAA. HIPAA protects you from things exactly what they're explaining happening. So my question is, if somebody's in an appointment and something's going on that they feel shouldn't be going on, how do you tell the doctor that you feel uncomfortable with what's going on, or that you don't think they're, because it's hard, how do you tell the doctor that you go to a doctor because they're supposed to know what's correct and what's not, but if you internally feel like something's wrong, either legally or also just like Dana was talking about, she just didn't feel like something was right or something's off and it's not just Down syndrome, how do you bring that up to the doctor without being rude or getting raising your voice and things like that?
So I will say this, is that whenever you go see a doctor, they're offering you an opinion, right? So that's why they call it a second opinion, is that, your doctor will try to put all the information together for you based on the history, based on what you're giving them. So what my usual preventative step is to come hyper-organized. So if you're worried about regression, that's the first thing in your mind. Come in with a detailed list, and I would say print it out, because sometimes it's hard to remember. I don't know. Even when I go to my own children's doctor's appointment, I just have, verbal diarrhea, and I can't get the, what I want to say out, and I forget everything. So I say print it out. this is what so-and-so was able to do before, and then this happened, and this is what they're doing now. So that way it's very clear. Everybody has a cell phone. Take a video. If you're worried about something, right, or you have videos of your loved one who's doing something fun, usually birthday parties or special events are the time where people light up, compare that and show the doctor in the room to say, look, this is what was going on before. You show them a video and keep it short, right? Nobody's gonna watch a 20-minute video of birthday celebrations, but show them 60 seconds of what was going on before and show them that this is different. Because I think that a lot of the time, especially when you're going to see a specialist, right? Primary care is different. They may know your loved one for many years, but specialists are meeting you for the first time. Now I'll use an example, the young woman who was touching her face back and forth. If I walked into a room and I didn't know anything, I'd say, okay, well, she looks like she has autism, right? But when it was explained and mom brought up the videos and said, this is her 3 months ago, and she's not doing any of it, now it's very easy for me to understand that there's a big drop-off or difference. But the number one thing is, don't get frustrated. Because if you get frustrated or if you go in guns blazing, that doctor's gonna be like, this is a difficult patient, right? How many people have heard the crazy mom or the crazy dad, right? Like, you don't want that because it's not gonna help you in the long run. You can even say, look, I've brought some literature. I brought a checklist that the National Down Syndrome Society uses about regression. What do you think about this? So come prepared and know what you want to say, because the easier you can communicate, especially when doctors' visits are getting shorter and shorter, the faster you can communicate it and the more clearly you can communicate it, the better the doctor is going to be able to understand. You may still encounter somebody who's not very good or is uninterested. And I think that, Dana and everybody's said this many times, I will talk to an upturned broom if I have to. But doctors that aren't curious or doctors that won't reach out when we try to make it easy and lower that bar, those are the doctors that you don't want to have. If you don't know something, that's fine. Not everybody's going to know about an ultra-rare disease that affects a subpopulation of people, right? Especially if you're a general neurologist, general psychiatrist. So if they're unwilling to reach out, or if they're unwilling to get help, or unwilling to ask a colleague, then you really need to just move quickly onto another doctor who's willing to cooperate. But I've worked with everybody from family medicine doctors to super subspecialists, and as long as you're curious and you want to help your patient, things get done. And I think Darcy's a great example of that, of having some really great doctors after some initial frustrations.
I think we'll open it up to questions now. So Emily, if you want to bring the mic to anyone that has questions.
We can do that. I do have one more question, and it could be Dr. Santoro or Dana. Insurance is confusing. Even myself, as somebody who's helping out our athletes figure out insurance, Medicare, Medicaid, I have stacks of books on it, and I still do not understand it. And Dana was talking about the appeal process and having, with these kind of disorders, or even just with anything from autism to Down syndrome, insurance companies, it may be hard to get things approved. Is there somewhere you can go to get help, or how do you navigate the insurance? Is that something that they can ask their doctors about? Is that something they ask the front desk about, or how does somebody deal with insurance?
So I'll give you the brief summary. Insurance is designed to be very complicated. They don't want you to understand it, because if you understand it, you can get what you need. So I actually found one of the best things to do if you're unsure is to actually use ChatGPT. This is one of the best things that you can do, because all of the health plans actually have to be published online. So you can go through it. It's just 1,000 pages of jargon. So you can actually use it to say, this is what I'm concerned about. What type of ICD-10 code should we be using? What types of therapies get approved on Aetna's blank, blank, blank policy? And it will spit it out. It's actually very effective at that. So you can say, this is my health plan, include the link. Say, my daughter, son has been diagnosed with this condition. We're trying to get this therapy, and it will spit out exactly what you need. The best resources, though, are usually the nurses. Doctors don't know what to code. I mean, I do, because I have to argue with insurance companies all day now, but usually it's the nurses who are going to know the most about it. But it's a challenging process. You have to write the right language in the notes, you have to make sure you're using the right codes, and it's a designed system so that you don't get the therapies that you want, or you don't get them in a timely fashion. So have some perseverance with it, but you can also talk to your health plan as well, and I'll turn that to Dana to talk about that.
You know something that, because I have a private insurance through my hospital that I work at, their HR program, when the first denial came and it was just getting a roadblock of those denials, there was an advocate through the HR that worked with Aetna. So my employer had kind of like an advocate. So I feel like that advocate helped me navigate through Aetna. I don't know if every insurance has that or if it was just unique to us, but I found that helpful.
Oh, sure. I'll do the runner.
Okay, we're gonna open it up for some questions from our crowd here tonight, and Jonah will just swivel around with our iPad for the online viewers. Don't be shy now.
So I understand that time is of the essence, but what if you didn't? What if you didn't realize for another 5 years? Is it realistic to follow the money trail and see how much progress a person can do, or is it too late?
So what we find is the magic lead to get the best results for PSRU is less than 2 to 2.5 years from the time the symptoms first pop up. That being said, we've treated everybody, I think our longest implementation is probably close to 2 decades at this point. It is a much lower rate of response, so your likelihood of response is lower, and even if you do respond, the amplitude of the response is less. What I look at this way is that difference between functioning at 20% of your baseline and functioning at 50% of your baseline may be significant for quality of life. And I think it becomes a very personal decision. But you talk to families about it and say, look, I think it's worth trying to get this worked out. I think it's worth trying to use therapy. And if it doesn't work, at least we can go to bed and say, we tried. I'm not going to do the white flag super early, but that's also projecting out the way that I do practice.
Great question. Other questions? Lexi, you have a question? Okay.
I know you didn't need a discussion for us. There's disabilities on life, your health. I like Jonathan, you did a fast turn and hammer down one time because of one of my friends. Thank you.
That was a cool shout out to you, Darcy. Lexi said you guys were good friends for a long time. You want to say anything to Lexi?
I've known Leslie since maybe I think track and field because she kind of helped me a little bit and I really enjoyed being with all my friends, and I really enjoyed being with like all the athletes. And I just want to say thank you, Lexi, for that question.
She said, "You're welcome. You're doing a great job." I just have to say, 3 years ago, Darcy would not have been able to just say what she just said. So it's very emotional to see how incredible Dr. Santoro's work is in getting Darcy back to talking on the microphone. So amazing. And I know that Darcy has family here, and they can attest to that too, that for sure. Have you ever seen her get on the mic again? Look at you, you're a pro. Yeah, woohoo! Any other questions?
They don't have to be anything about Down syndrome progression. They can be things about health too.
Yeah.
Anything on the table.
Yes. Darcy, what did you decide to cook for your first time in Darcy's family?
I think my first ever cooking episode has to be well, first off, I love to cook, and well, I got to cook. Just today, I started making healthy tacos. And it's one of my favorite dishes to make. So I've enjoyed cooking a lot, and that's one of my goals.
Good question. All right.
I feel like I'm taking all the questions.
No, take them all.
And I don't know if this would be for Dana or Dr. Santoro, but thinking about the logistics of healthcare in California, where we live in Alaska, and traveling is not easy. Just logistically, it's hard to travel with your son, and of course, it's also very expensive. What does the process look like?
Yeah, I understand we're not like one another. So I'll say this. So oftentimes we try to get as much workup done locally as possible. So that way it's not like a lot of extra stuff when you have to come out. I think Darcy was a good example of that, where we had probably 95% of the workup done before she came down to Los Angeles. So it was an evaluation, a diagnosis, develop the treatment plan, and then using the local doctors to help execute the treatment plan. So my problem is I can't do telehealth remote, out of state. It's just our hospital policy. But after we do a single consultation, it makes it really easy for us to work with other doctors. So about almost 40% of our patients at this point come from out of state. So we're used to and have infrastructure to do that sort of stuff. That being said, my dream is that we have a day where nobody has to get on a plane to Los Angeles. It's a beautiful place, and certainly during the winter, it's not the worst place to be in. But it's tough when you have to, think about going thousands of miles to get healthcare and to get diagnoses. So we're trying to look at better ways for us as doctors to train other doctors to have this. Now, I'm not certain we're going to have Down syndrome neurology specialists in every state in the country, but as many of those touch points as we can, so that way they can say, hey, I've worked with these specific patient populations, and then you can develop that spoken hub, model for the future.
And I think we talked, kind of mentioned, I was like, you just need one physician that is going to be clinically curious to reach out to Dr. Santoro. Like you said, he talks to a room. You just need a physician to reach out, and we can do that. You can do the education. So I was very thankful. This morning, Dr. Santoro did 2 presentations to physicians at Providence. So we're opening up that knowledge of this is a diagnosis that's treatable, it's identifiable, and so it's just the beginning. And I see one of our wonderful physicians here, and she would just reaches out to Dr. Santoro when they collaborate together. So you just need a physician that is willing.
Thank you. Other questions?
You mentioned that this is like kind of new research, obviously it's only been 5 years since you said. Are there other healthcare professionals in like the US or even worldwide that you know that are doing the same research? And then the follow-up question being like, what is the best way to support the research that is being done?
So in the U.S., I'd say it's probably us and the Cernic Institute in Colorado, which is a very large Down syndrome center there. Internationally, not so much. We have a group in Amsterdam that's trying to help along with some of that, and I think probably France is probably the second place where we're getting a little bit more traction on trialing immunotherapy. But it's tough because in each other country, the healthcare system is very different. So we have a lot of queries that come from the United Kingdom and Ireland, but their nationalized health service is very restrictive on the therapies that we would be prescribing. So it's often hard for us to give advice to them because it's just, we don't even know how to begin the navigation process for that. The best way to support the research, though, is let your Congress people know. So the NIH or the National Institutes of Health are who fund the research for these types of rare and ultra rare conditions. So I look at it this way: is like if you want to do preventative therapies or identify blood testing and say, hey, you're at risk for DSRG or you're at risk for epilepsy or whatever it may be, the only way that we're going to be able to invest in that is through the National Institutes of Health, because companies don't have the incentive to develop specific tests for specific diseases in specific populations, right? It's the same way why aren't there different drugs for people with Down syndrome? I think that the best space for this is thinking about Alzheimer's disease, right? There's 3 FDA-approved therapies for Alzheimer's disease. One got taken off the market, but there's 2 others. None of them were tested in people with Down syndrome, right? And it becomes very easy for a drug company to say, we want to exclude this patient population because they're too risky or they don't have the same exact features, when that's something that National Institutes of Health, the FDA, can actually say, you need to include this population so that way we have an extra set of therapies for it. So talk to your Congress people. If you email them, especially up here, there's not as many people, you can email them and you might actually get a response back. So you got to demand it sometimes, but the NIH is a really valuable resource for people with Down syndrome.
Speaking of research, Dr. Santoro and the Children's Hospital, they have the Down Syndrome Symposium that we did. Tell how they can donate to that, because that was, you guys raised money for that. And so that funds Dr. Santoro's research. And I'm going to talk about things that I don't know very much. But the fact, he spoke in his other lectures of like how quickly you got that research approved, because the NIH was saying, hey, this is huge, we're seeing this. And so you were able to do that research faster than typical. And I was thinking too, what knowledge would I have needed 3.5 years ago if I would have known about the National Down Syndrome Society, the DISMIC, which is the Down Syndrome Medical Interest Group. If I would have known about those organizations to reach out to, I might have been able to get some answers and been able to find out more quicker. How do they get the information on that?
So online resources are really great for finding things out, but I think that just to highlight the example of how fast we're moving. So in 2022, we published the paper on these are going to be the standards for the diagnosis of DSRD. The next year, the NIH said, run a clinical trial. And that was, I mean, normally if you find a phenotype and then you want to develop a drug or use a therapy, it takes about a decade on average. So we did it in 1, and we fulfilled our promise to the NIH. We're finishing that trial 2 years ahead of schedule because of how much demand there is from patients who need therapies. So I think that this is one of those things where, the proof is in the pudding. If the NIH is going to give you money to run a study, they want to see return on investment. And I think that that's what really galvanizes the community of people with Down syndrome, is that engaging in the research actually helps you get more research dollars in the future as well.
And I quickly wanted to loop back. I'm jumping back over here, sitting in my chair. But speaking of talking to your government officials and things like that, I wanted to make a plug for our Disability and Aging Summit that is tomorrow and on Wednesday from 8 to 4. But on Wednesday at 10, we will have a panel of legislation and some people from the Alaska Mental Health Trust Authority and the Governor's Council will all be on a panel discussing issues with just topics about intellectual disabilities and laws that are being put in place, Medicare, Medicaid, transportation, things like that. So I recommend if you guys are able to come and you can ask questions to them directly, but then also on Wednesday at 1, we are doing a class on how to write to your legislation and how to write letters to your representatives. So if that's something that you're interested in coming to, it's free and it'll be at this building. The setup will look exactly the same, and more information is on our website, but I wanted to quickly plug that. So I was also going to say, if we don't have a ton of more questions or anything, I wanted to open it up also with the family forum. We try to get families to interact with each other and kind of talk about their own situations or get information from each other and just kind of talk. And so I was looking at the time and I wanted to open it up. You can still come up to Dr. Santoro and ask him questions, but also just wanted to mingle. We have snacks over there, things like that. So I think I'm going to open up to that. So don't go yet, just hang out and talk.
I have one other question for Dr. Santoro. I feel like I'm picking your ear while you're right now. You say that I think it is 1 to 2% of the population, but yet research, you've only been identifying it and treating it for 5 years. Do you feel as the awareness increases and people are getting the diagnostics and do you think it has the potential to have a lot more than 1 or 2%?
So yes, the short answer is I don't know. And the challenge is the only way that we can really track it on a national level is to have an ICD-10 code. So when you go and see a doctor and they say eczema has a numerical code that gets put in there too. There is not one for Down syndrome regression disorder. So you have to code it as encephalopathy, catatonia, and all of these other little terms. So we don't know on a national level what this number could be. I think that number may move over time. Very similar to autism, right? When autism 20 years ago, we really didn't understand what it was, or it was not diagnosed really efficiently. Now we're seeing that it's diagnosed in a much more standardized way. I think we'll see something very similar with DSRD. I could see it as anywhere from 2% to 5%, probably not beyond that. So it's still a very small minority of people with Down syndrome who develop this. And we're working on the ICD-10 code. So the CDC has to approve it. They did not approve it this year, unfortunately, but we will get it across the finish line at some point.
Okay. Well, somehow an hour has already gone by and it feels like it went by in a blink of an eye. So we do want to take the next 30 minutes just to be able to have open conversations with your peers, with Dr. John and with Dana, and to get snacks. So one more plug for tomorrow. Tomorrow's Disability and Aging Summit kicks off with the keynote address from Dr. Santoro at 8:30. If you haven't registered yet for that, you can. It's not too late. You can just do it when you even arrive. We do have over 200 people registered, so we're going to figure out the online piece because I think there's a bunch of them hoping to get online. So Nicole, if you're still on, I might be picking your brain on how this worked with the YouTube. If you're not registered, please feel free to just come tomorrow. There will also be a lot of other discussions that will be very helpful just as you navigate life and aging. There will also be all these vendor tables that are around the room will be filled with vendors, and these are resources for you as family members. Just looking around the room up there, I see the ARC, UAA Center for Human Development. We've got the Governor's Council on Disabilities and Special Education. We'll have a booth, and then I wanted to just have Sam just give us a wave. If you haven't heard us talk about our partnership with Providence Hospital yet, Special Olympics has partnered with Providence, and they have actually created a position that Sam holds, where she's a liaison for families to get direct access to follow-up care. So think of needing to call and make an appointment with a primary care provider, or maybe even figure out how to get referrals for a specialist, things like that, and you can't figure out navigating the online system. She is your direct line make sure you visit her and grab a business card. She will be able to help you get connected to that follow-up care that's so important on your health journey. And without further ado, I think we'll go ahead and we're going to sign off from the online crowd. So thank you online for joining us. And then we'll go ahead and turn our mics off and feel free to come up, have a conversation with our panelists here. And we hope to see you as well throughout the next 2 days of the